So we are in week 5. It's going by very quickly. As I said, it's before you know it, we're going to be into HESI. So week 5, we're going to do cardiac and we're going to do respiratory. Probably my favorite of all the body systems. I am an absolute cardiac nurse. I worked for many years at Nicholas Children's Hospital, which was a forerunner in cardiac open heart surgeries with some of the biggest, best surgeons in the world. So I love cardiac. Any questions about it, ask me. I'm going to try to make it simple for you because it can be overwhelming. And we'll see how cardiac respiratory works together. Know that you do have a quiz next week. It's on cardiac and respiratory. So I would go over that cahoots a few times and those concepts so that you know what to do for that. You do have another discussion question and you do have the CJ Sims Khalil Taylor that is due. Now, I don't know what your other classes are doing for like with homework, but know that week 8, 9 is going to be rough on you. So if you can start getting your pediatric clinical assessment into me, number one, what do you want to do? I have to approve it. Is it going to be on autism? Is it going to be on asthma? Is it going to be on whatever child diagnosis you want to give me? You want to give me a syndrome? You want to give me things like Pierre Robin or a DeGeorge or yes, I know all of them. Just give them to me. In fact, I like it when a student finds a diagnosis that I don't know about, and I'd like you to teach me. And I don't want you just to find a weird diagnosis. I want you to find something that either you, your family, your neighbor, or you saw in a hospital, something you want to know more about. And if you write it that way, it's not going to be as much of a chore. Now, as you do the 3 sections, remember there's a paper, it's only 250 words. It's not big. Make sure there's references and citations within the body of the paragraph. The second part is probably the most lengthy. It's that assessment form. It is in your modules. You can print it out, or I can send you a Word document with it on. Whatever you need, let me know. The biggest part of that assessment form is going to be the last part, which talks about theorists and how are you going to do nursing care to that patient at that age when you're looking at Erickson or Piaget. So psychosocial around people, or we're talking about cognition, Piaget. So how do we work with them? And then there's 3 nursing diagnoses. Make sure it's a diagnosis related to as evidenced by. Those are the 3
Is there a
components
template for
of
this?
your diagnosis. That's all there in the
I couldn't
modules.
find it.
Go to modules, click on clinical pediatric assessment. It's going to bring you in it. If you have to, after all the rubrics, I think you go to the
What week?
next page and it should be there. 8,
8.
week 8, week 8. I can also send you all that pediatric assessment assignment when I send you your thing for today out. So just if you want to get ahead with it. Now, the third part, don't overdo it. It's either PowerPoint, it's a picture board, or a brochure. Teach me about that diagnosis. Is that a diagnosis that has to do with diet? Does it have to do with medication administration? Does it have to do with manipulation of the environment for like that ADHD person? Tell me, teach me. 5, 6 slides. I don't need anything crazy. Teach me something. It could be how to do an inhaler, could be how to give a G-tube feed, could be something that simple. All right. Teach me. It's like you would be teaching either that parent or the child. Make it kid-like. Put pictures on it. Pictures are fun for kids, right? So it seems less threatening. Any questions about that? And if you do, send me a message. And as you are doing these sections, if you send them to me early, I will correct them, send them back, and show you how you can get the points that you can get all the points if you want, if you go back and just redo a couple little things. And I'll show you how to do it. If you don't understand it, we'll get online, we'll do it together. I can help you format papers, whatever it is, all right? Because this is an associate degree program, and I know today, now remember, I'm an associate degree RN. I was for 33 years. Then I decided I had to go back to school. And I went back 15 years ago to do my BSN, MSN, PhD. So I know what it's like to come back to school and to go through this. So, all right, let's go and let's do our cardiac program. All right? Or should we do respiratory first? Well, we're going to do respiratory. It's just the way it's set up. So now, the one thing I want you to remember is the differences between adults and children and the similarities. Now, the one thing that you guys are lucky with, I'm an adult and pediatric nurse. I've done ICU, ER, open heart surgery in the adult world, and I've done all of that in the pediatric world. So the differences, I know them because I've seen them. So when we talk about respiratory, it starts with the mouth because this is all that leads into the lungs, right? So it's the nose, it's the sinuses, it's the trachea, epiglottis, and all that sort of stuff, right? So you have the upper airway, it's before it goes into the lungs, and then you have the lower airway. Lower airway could be a pneumonia problem, right? Because that's down in there, or even asthma because air gets trapped in there. Now, what are some sort of things that causes upper respiratory infections? Well, you've all been told you go to the doctor, you've got this cough, you've got all this mucus, you're miserable, you got a fever, and you say, oh, you got an upper respiratory infection. It's a viral disease. So just take acetaminophen, ibuprofen, alternating, increase your fluids. Children always make sure any fever, increase fluids. That's a big thing because they just evaporate it right out. Now, if I'm telling you mostly viruses, so mostly we don't have to go to the doctor and be told, right? Well, the parents will always bring these children in. Now, one of the type of viruses that could be a little bit more difficult, especially with the young infants. Now, remember, infants are 1 year and less. Up to 1 year is still an infant, okay? So when you or me get a cold, we don't feel good. Runny nose, sore throat, cough, headache, feel icky, right? Now, an infant, what are they able to do in the first year of life? Well, they start with suck, swallow, breathe. Well, then you give them an RSV, which is a virus, gives them a little nasal mucus. They only breathe through their noses. So obligatory nose breathers. Now you've clogged that up with mucus. Now they're trying to suck, swallow, and breathe, and now they're into respiratory distress. What would you see in that infant in respiratory distress? Well, all the things you would see with adults, but infants, nasal flaring, and when they're really bad, at the end of a breath, they'll grunt. So they breathe and go, eh, eh, eh. It's almost that sound. And when you hear a baby grunting, go to the trauma room. You are very close to intubation, okay? So that's the differences between RSV, between adults and children. Now, what if your child was also immunosuppressed, cardiac child, a child with cystic fibrosis? You don't want them to get RSV, do you? So there is an immunization called Synagist. And we're going to go on that in a little bit. I just want you to know, very important medicine, Synagist, and it's used for the first year of life every month. So once a month, and they say late fall, early winter to early spring. So like 6 to 8 months. Now, I live in Florida, so what's fall, what's winter, what's summer? So again, it's the first year of life, monthly, once a month, okay? Now, talking about infants and talking about getting infections and upper respiratories, we need to understand why these children are starting to get these sort of illnesses. Well, initially, mommy gives everything to the baby, right? That baby's got all those antibodies and all that good stuff, and they start to die off, like the blood cells, the red blood cells. Everything starts to die off. So now the child's immune system is weaker. Why do you think we give all those immunizations at 2, 4, and 6 months? Because look, infection increases between that 3 to 6 months. So we want to give them protection against the really bad diseases that are protected with immunizations, okay? We know that as they get older, it's not going to be as many viruses. We know that toddlers swap spit all day long, so that's how they get all of those viruses, and we build up all those immunities. And by the time they get in school, which is about that 5, 6 years old, they're more into the bacterial infections because they fought all these things because everything's in the mouth as a kid. And we know as we get diseases, as we get our immunizations, we have an increased immunity. That's just what it is. Now, ear infections are part of respiratory. It's all part of this upper airway thing. And what happens with ear infections? Well, we know fluid likes to go from the most resistance to the least resistant. So go from here to here, makes the flow go easier, it will go. So just think about, you have a tube, an eustachian tube, to the back of the throat, and it's full of mucus in the back of the throat. That mucus needs to go somewhere. It goes up into the eustachian tubes, into the middle ear, creating pressure and infection, and always is treated like a bacteria. Your mouth is always with staph. Always. Your nose is always with staph. It's just part of it. It's just we live. But when it gets into that inner ear, it hurts. Okay. So what do we treat otitis media with? The infection of the middle ear. Well, we go very, medical, pharmacological to start with. Number one, it hurts. Give this child some acetaminophen or ibuprofen. Honestly, me, it's just my personal choice as a nurse. I would always give ibuprofen because I think it's anti-inflammatory and said, if they're old enough for it. But whatever they have is fine. So you treated the pain. Now, it's also antibiotics, amoxicillin, augmentin, it depends how many ear infections they've had, et cetera, et cetera. And they make sure that we take that for the whole dose. Also, parents need to be taught to go back and be checked, the child to be checked to make sure that infection did go away, because ears do hurt and we want to keep their hearing. Now, there becomes a time where you're having all of these ear infections. Sometimes you have to go and get the tubes put in your ear. Believe it or not, last August, I had a tube put in this ear with all of the sinus and all of the ear infections. I know what an ear pain feels like. So those tubes are a very quick procedure, but it's done in the hospital for children. So the reason why, as I said, why does it flow there? Areas of least resistance, all this music, it's open, it's wide, and it just flows right up into the ear. And that's why that pain causes it. Now, a kid, when they're sick, ear infection, upper respiratory, pneumonia, anything, what does a kid do? Well, first thing they do is they stop eating, right? They don't want to eat their favorite food, their favorite juice drink. No, they don't. They might be sitting in the corner, not playing. And of course, they might be, holding their ear or their tummy or whatever it is. You might see a fever or meniscus, but, that's to the extreme. But they usually will vomit. They have a fever, they'll vomit, and they just don't feel good. And then you start listening to the breath sounds, and you hear all of this mucus upper airway, and you see the bronchi in the lungs, and you know that this is what these kids go through. So when we're working with respiratory dysfunction in children, what is our nursing care? What is our goal? Well, if you can't breathe, we want you to breathe easier. If you can't rest, we want you to rest easier because you need to rest in order to feel better, right? Making sure everybody else doesn't get the infection. That means washing hands for nurses, as simple as that, and the child to use tissues or elbow, whatever, to prevent this from going into the air. Also, reducing the temperature. How do you feel when you have a fever? I feel horrible. I feel achy. I don't even want to lift my head. The children feel the same. Now, is it mandatory to treat a fever? Is there anything going to happen if we don't treat that fever? And the answer is no. There's like maybe 1% chance. The fever, why we treat it. I see you, Erin. Why do we treat a fever? It's because of the discomfort. When do we have bad outcomes with fevers? It's a febrile seizure. That means we went from 0 fever up to 102 quickly, the rate of rise, that causes a seizure. You can't get into medicine quick enough because you don't see it happening. A normal, everyday, I'm just sick with an upper respiratory, don't feel well fever, you treat it for the discomfort, not because it's going to have a seizure. Because once you have a fever, you're safe, right? It didn't go from 0 to big fever at once. That's the difference, okay? Now, infectious mononucleosis, the kissing disease. Has everybody heard about that? It's like all the teenagers kissing each other or sharing glasses or straws or whatever. Well, it is a Epstein-Barr-like virus. So it's a virus. What happens is it presents sore throat, like flu-like symptoms, fever, fatigue, body aches, swollen lymph glands. But the one thing that we're most concerned about is the swollen liver or swollen spleen. Blows up like a balloon, okay? Swells up. So these children, very hard to actually diagnose. These kids go to the doctor and they go in with a sore throat, flu ache, body stuff. They do all the tests. They do a strep test. They do a culture. They do a flu test. They do RSV tests. They do all the tests, and they're all negative. And they say, okay, you're a virus. So send you home, increase fluids, acetaminophen, ibuprofen. Well, 3, 4 days later, they're still sick. They go back to the doctor, and the doctor says, well, we don't know, so let's just order you antibiotics. This is a true story. I've heard this over and over again. Oh, about 3 more days later, they're still sick, don't feel well. Then they're going to come to my ER and they're going to see me and they're going to give me this whole scenario. And what we're going to do is, with the symptoms of sore throat, aches, pains, fever, swollen lymph nodes that first was treated like a virus, then antibiotics didn't help, we're going to do blood. Why would we do blood on this child? We're going to do a CBC. What's the CBC going to show us?
Is their white
Do we
blood
have an
count?
absolutely, yes. Is the white blood count elevated? And that will show us it's a bacteria, right? Well, this one's not. So we also do something called a monospot test. This monospot is a blood test, and it shows you have mononucleosis. So now you have your diagnosis. So this child who's been suffering for this week, in and out of the doctors, it is a virus still. It's still going to be treated with acetaminophen, ibuprofen, rest fluids, but now we know it's mono. What are the nursing protocol for this? Well, do you remember I told you about that spleen or liver that blows up like a big balloon? Well, if it got hit, it could pop and burst and rupture. So this is all about restricting physical activity, PE, for at least 3 weeks, and until cleared by the physician, can they go back to contact sports. I'm going to tell you a story. It's not a nice one, but I'm going to tell you about a little boy, 9 years old, that came with his father one Saturday morning that had absolutely what I just said. Gone to the doctor, went back, got antibiotics, came back to me, did the blood test. He was mono. I taught the father, I taught the son. The physician was a great physician. He told him about contact and making sure you keep the belly safe, blah, blah, blah. End of story. 1 week later, I'm the trauma primary nurse on duty. Copter call comes in. It's this little boy. He was in the Everglades on an ATV, fell off, fell in his abdomen. His spleen burst and he was dead on arrival. So, why do I tell you this story? This is a child that maybe with more, and we did a lot of teaching on this child, but just to let these children know that protect that abdomen, that spleen or that liver can burst and they will die. Now, bronchitis. We have the bronchus, tracheobronchitis. We've got all of these irritations of the airways. Now, Bronchitis, I think, is the most annoying of all of these things. It is a dry, hacking cough. Nothing comes up. Your ribs hurt, and it's worse when you're trying to sleep. It's like you're coughing, 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 coughing. And at night, you want to go to sleep. You're so tired and you just can't because you're coughing. Usually there's no fever with this. It's just this really bad cough. So how do we treat it? Well, analgesics, probably for all that coughing, probably hurt. Antipyretics, if you have a little fever, but usually not. And that humidifier is really good for this one. Bronchitis, a lot of the children, parents say when they go from the indoors, they go outside, that moist air actually will stop them from barking as much. Um, but cough suppressants, whether it's cough medicines, cough lozenges, whatever it is, to try to give them some sleep. So bronchitis, dry hacking cough, mostly at night. Now we go into croup. Now, croup is not just bronchitis, it's a laryngotracheal bronchitis. So it's the larynx, trachea, bronchus is all swollen up. And what happens with anything in the oral airway, it swells, air can't get in. It's trying to get in. And then with croup, the way it's so irritated, they cough. And when they cough, it sounds like a seal. It is the most distinctive barking sound on a child's cough that you'll ever hear. You'll say, oh, that's croup, and you'll just know it. Now, acute laryngeal bronchitis, again, it's another virus. How do we treat swelling in the oral pharynx with croup? You give steroids, whether it's oral, IM, it doesn't matter. Usually one dose or sometimes 3 doses. So usually croup, you've already had this little infection and it's just continuing. And then all of a sudden you hear that as you breathe in. Breathing out's fine. You can't go in. So if you can't breathe in, you're going to see those suprasternal retractions. You're going to see pulling in between the clavicle. You're going to see intercostal retractions. You're going to see that really bad barking, seal-like. And then as it continues, your air is not getting in as well as it should, and it can lead to respiratory acidosis, or it could lead to respiratory failure, or it could turn into acute epiglottitis. Now, epiglottitis is a real, true emergency. Let me tell you why. The epiglottis covers the trachea when we swallow food, so food doesn't go into the lungs. Pretty neat thing. Well, an itis means inflammation of, so the epiglottis is swollen, and it's covering that trachea, and it's not allowing air in normally. So you're trying to get air in. So your throat hurts. It's painful. You are in every sort of senior position of how to breathe, leaning over, tripod positioning, going to the right, left, put your head up and down, trying to find that little airway that's open to get air in. These children, they can't talk. They're when they talk, and drooling. They can't even swallow their own spit. This is true and real emergency. So as an RN, what do you have to make sure to keep this child safe? Well, you or get somebody, get a intubation tray and a tracheostomy tray at bedside, because that airway could completely close at any time. And you don't know if that oral endotracheal tube, if there's any room to get it in there. You might have to do that tracheostomy tray right at the bedside. So acute epiglottitis, drooling, this is a child who can't breathe, and it's a true emergency, and make sure you have proper equipment at your bedside. So again, any of these sort of airway things, make sure that you have everything that you need at the bedside, right? Always put them in position to have their airway open. You don't want them, you want the air up and the airway open. All age people, doesn't matter. And of course, if they can't breathe, they still need to be hydrated nutrition, so IV fluids if they need. If they're good enough, they can drink, but usually, you know, the ones that are more severe, they'll be on IV fluids until we get that respiratory system calmed down a little bit. This nebulized mist is great. Little masks that have little water steam in it with oxygen if you need it, or just air, really helps them breathe a little bit easier. Now, the problem with younger kids and this nebulized mist O2, if they're admitted, they're going to go to the room and they're going to order tents. Most young kids don't want to get underneath that tent by themselves. So, what would you do? Well, either have the parent climb in underneath with them or put it in their face. Take that hose, that mist, put it in their face so at least they're getting it, and have the parent hold their child. They're happy, they're comfortable there, and they're not stressed, and they're getting all that moist air. That's part of it. Now, also, how do we get rid of all that swelling and all of that irritation? We're going to give epinephrine if we need it, whether it's in an aerosol or sub-Q, and of course, steroids. This is another steroids. So again, this is your RSV. I mentioned it earlier, just to briefly go over. Usually it's the first year of life that we do prevention, and it's called Synagis or palivizumab. It's a biologic, okay, from winter to early spring. And these are for your immunosuppressed, your very sick kids, your premature children, your cardiac kids, children that can't, have that extra mucus, that extra work of just breathing and eating, okay? Now, common kids, tonsillectomies, right? So these children usually are coming in as an outpatient today. They come in, they have surgery, and they go home. So a lot of nursing function is going to be how to discharge them so that they can take care of themselves at home, right? So making sure that they avoid all sorts of irritating seasoned food, like no lemons, limes. I mean, I had a brother who had a tonsillectomy and wanted radishes with salt on it. And actually, the surgeon told him, go ahead if he wants it. And he did. But the salt was good. So that's why. But usually, no irritating, highly seasoned food, nothing in the mouth, no vigorous anything, no gargling. Not your tooth, brushing your teeth should be very minimal. If you think about what a tonsillectomy is, they have two big things on the side of the throat, right? The tonsils. They take scalpels and they cut them off and cauterize it. So there's big scabs, literally, left in the back of your throat. So anything could make a chunk of that scab come off. And I have seen a little girl almost bleed out, go into hemovolemic shock, requiring a liter of fluids because of bleeding from post-TNA. Okay, so again, leave that throat alone, nothing in there. How do we take care of these kids? Well, today we're just giving acetaminophen for pain. It's enough. Again, they should be resting so that we don't take one of those little scabs and knock it off and create bleeding. And the connection of the ear tubes with the back of the throat in older kids feels like they're going up in an airplane. So they get that ear pressure. So just like an airplane, they chew gum. And that helps with alleviate the pressure. The older kids can do it. And again, if it's going on and it's 10 days post-op and they're still smelly mouth, etc., then they need to be taken care of. But usually within 2 weeks, they're fine. Now, types of pneumonias. Well, you think of pneumonia, you think of just that, left lower pneumonia, right? Well, remember that children can inhale things like chemicals and powders and stuff. That's why we don't do baby powder anymore. There's bacterial, viral, mycoplasma, pneumonia, pneumococcal, and we do have a pneumococcal vaccine now, which that was a really bad pneumonia. So now we've got some defenses against it. Now, aspiration pneumonia. This could be the powder. I mean, years ago, we had powder in the NICUs and we put them on the babies because Johnson & Johnson baby powder, it just smells good. So we would put it on, you just smell of that good stuff. We found out that powder in the air was getting in their lungs and creating problems. Again, in time with research, we find out everything. The other way that they can get aspiration pneumonia is by eating, by that reflux, that GERD, gastroesophageal reflux disease. And that little bit of reflux is going into their lungs and causing these little mini aspirations. So again, teaching parents how to feed a child, burp them, sit them up when they're done, not overfeeding them. The other thing children do is put everything in their mouth, don't they? I think one of the most common things is a quarter. Not a penny, not a dime, not a nickel, a quarter. Why they like them, I don't know. But they put it in their mouth, somebody does something, and they inhale it, and it's stuck, and it hurts trying to go down there. What we do with these children is usually they come in and they're just hurting and they just a little bit can't swallow all of their mucus. But if they're not in respiratory distress, do the x-ray, find out where it is. How do you think we get that out of there? Years ago, it used to be a bronchoscopy. No, believe it or not, they take these children, and usually they're like that 2 to 5-ish area, that put it in their mouth and swallow it. We put them on the surgeon's lap with the parents holding their hand right there, and we put a Foley catheter down the throat. Blow up the balloon below the quarter. Child leans forward, we tell him to cough, and he rips it out, just pulls it. And the quarter and mucus or vomit will fall on the floor. Now, I'm going to tell that child, now when that quarter comes out, whoever gets it first gets to keep it. So this comes, he's not afraid, he's looking for the quarter. I'm looking like I'm going to grab it. I'm not. The kid gets it and said, I got it first. And he didn't even think anything about sitting there getting the quarter ripped out of his throat. Again, distraction, distraction, distraction. Again, kids gag and choke on things. I've seen French fries, I've seen peanuts, all different things. So again, small items. Now, pertussis. Why do we cover pertussis? Well, pertussis is a really bad airborne disease and it's extremely contagious. But you're going to say there's vaccines. Well, not all children get vaccines. Some parents don't believe in them. And we did a couple years ago, had a big outbreak of pertussis. And it's because a lot of children who've not been immunized. Again, how would you treat this child? Number one, protect yourself with a mask and get that child in a reverse airflow room if we, as soon as we can, if we can figure out what's going on with the child. Hopefully, promote vaccines. Now, smoke inhalation. How do we treat smoke inhalation? And it's just giving air, oxygen, oxygen, oxygen. Again, smoke inhalation depends if there's structural or swelling also. But again, it's oxygen. Tobacco smoke is a big thing for children. Increased tobacco smoke in the household increases ear infections. That's one of them, to tell you the truth. It affects pregnant mothers and children growing, so it's not recommended anybody smoking in the house. Now, cystic fibrosis, pulmonary disease, it's inherited. It is a problem multi-system. It has to do with the lungs, and it has to do with nutrition in the small intestines, okay? So it's an increase of mucus, sludge that just sticks there. So in the lungs, we are going to be having mucus in there like crazy. So the other thing that happens with this child is an electrolyte problem. So have a child that's born and does not have a bowel movement in the first 24 to 36 hours, one of the things it could be, if we had no other previous clue, could be cystic fibrosis. It's called a meconium obstruction, okay? So if a child has cystic fibrosis, if we lick their skin, it would taste like salt. Now, I wouldn't lick the skin. You tell the parents, right? This child's going to be full of mucus. They're going to be coughing. They're going to be full of these infections. And of course, their lungs are going to have every sound with all of this mucus and built there. Now, the other part of cystic fibrosis is the digestion. In the small intestines, something in the pancreas does not like to digest fat. So fat is not used in the body. When fat's not used, it just comes out in the stool and it becomes the most foul smelling, greasy stools there are. I mean, they're foul smelling. And because we're losing all the fat from our nutrition, guess what? This is going to be a low gaining weight person because you need extra, extra, extra nutrition on these children. You're losing salt and you also are losing fat. So those two must be replaced. So how do we diagnose that cystic fibrosis? That little child who has not moving their bowels in the first 36 hours of life. One of the things, as I said, we'll check for is cystic fibrosis. And we do that with what we call a sweat test. Remember I said they sweat salt out their skin? They measure the amount of sodium in the skin. So that's how they do that. Now, how do we treat it? Well, you've got multi-system here, right? So with the lungs, you're going to be off and on antibiotics, whether they're inhaled, whether they're oral, whether they're a PICC line. I mean, this is a chronic thing. Also, they're going to be getting chest physiotherapy. Give an aerosol, right? Open up the lungs. Give chest PT, drain them out. And then we can feed that child. You do it before they'll puke. So make sure that we get those lungs open and let them eat. But remember, they can't eat because they have a problem with fat digestion. So these children are going to be getting something called pancreatic medicines, or one of the names is pancreatase, before every meal or snack. And what that does, it helps digest fat. Now, you need to know about these medications. If it's in a enteric things, you can't crush them, any type, whether it's the one for cystic fibrosis, whether it's another enteric, never crush those things there. If it comes in a little capsule, a lot of kids can't swallow that, but you put it on the food and give it in those first couple bites, that works there too. There's also powdered medicine, and that you need to rinse the mouth out because it can attack the teeth and hurt it. Just like some of those respiratory inhaled medicines that you need to rinse your mouth when you're done, the Symbicort, Advair, Brio stuff, same sort of concept, making sure your teeth stay healthy. And the one thing I think in pediatrics we forget a lot is to increase the dosage as they gain weight and they get bigger. Some kids can do 5-7 pounds in a year. That would make a big difference in doses. So what is our management? Keep the airway open. Make sure we put the bronchodilators, and we do physical exercise. What do you think a great physical exercise for cystic fibrosis could be? Playing soccer? Or how about going in a swimming pool? There's no allergens. They have to hold their breath, go under. That's putting PEEP in their lungs. It's the best exercise, believe it or not, is actually swimming. Again, any infections is aggressive, whether it's giving tobramycin, gentamicin. I mean, they do all of those in aerosols. They use, all of the big guns of antibiotics in the PICC lines. So again, all of this stuff we use. These children are in and out of the hospital, in and out with pulmonary infections, and again, monitoring their growth because of nutrition. So how are you going to feed these kids? Well, you're going to give them the pancreatic enzyme. We can give protein and we can give calories. So high protein, high calories. And give them a salt shaker, right? Because they're losing it in their skin. Remember, if they're born with this, they're a part of it is constipation, right? At first. So again, making sure that we make sure that child does move their bowels. And these children do have chronic reflux. So whatever meds, or just feeding them properly, sitting up afterwards, burping them correctly, not overfeeding. So one of the things, because the pancreas is the thing that's not functioning, the organ, okay? Because it's not functioning well, what else does the pancreas do? It puts out insulin. It has to do with diabetes, right? Many of these children with cystic fibrosis end up being diabetic later on, probably type 2 later on. So cystic fibrosis possibility is great. Cystic fibrosis in pregnancy. women can get pregnant. It's high risk, but they can get pregnant. One of the things is men. Now, we've talked about the lungs and we've talked about the intestines. Well, men, there's some sort of clog in their vas deferens, which means they can't get the sperm to the woman to have a baby. But if this man really and this woman really want to have a child between them, if they do a bilateral lung transplant for the cystic fibrosis, 1 year after, usually that clears up, and many of them have been able to have a child with their partner. So that's about cystic. Sleep apnea is just like me and you. You get, snoring, breathing pauses, all of those things. Again, children get it. A lot of that tonsils, adenoids, that's usually what we'll do first, right? After that, still going on, do the sleep study. We might have to do more surgery in there or not, but we're going to put them on some sort of CPAP, BiPAP, a mask, whatever can work on these children if it's that severe enough. Acute respiratory distress syndrome. This is when the lungs have been hit hard with something, infection, trauma, drugs, or how about being, underneath the water and now your lungs are full of water. All of these things damage the lungs. The thing with the lungs, though, sometimes it takes up to 72 hours before you see symptoms of declining health. So any sort of thing like drowning, you get there with the ambulance, the kid's up and running around and the kid looks fine. That kid will go to the hospital and will be admitted to at least a minimal step down ICU on a O2 sat monitor. And we will be monitoring their O2 sats because it up to 72 hours later, they could stop and their respiratory system could just shut down. So ARDS, sick person, again, trying to get them with their oxygen. I gave you this picture. This is a picture of ECMO. This is when a newborn born cannot oxygenate at all. And all we do is pull the blood out, we put oxygen in it, and we put it back in the child, and then we just let the lungs rest until they're ready. I actually got certified in this, and it's actually quite intense monitoring all of that. But that's giving oxygen, not by the mouth, but in the blood, we're giving oxygen. Any questions on CPR? You will see something on every exam on CPR, whether it's 1-man, 2-man, whether it's, worrying about parents, whether it's worrying about choking, how do you do those things? Always review your CPR. You'll always see a question on it. Asthma, one of the most common of all childhood diseases, right? It is a hyper responsiveness of the airway due to some sort of antigen, some allergen, something got it upset, tickled it, and now I can't breathe, right? Everything shuts down, and now we can get air in. Guess what? You can't get it out. My husband went into status asthmaticus and he went in for 12 days in the ICU. And if I listened to his lungs, you could barely hear air go in at all, but going out, all you hear was a and that was a big air moving. They really swelled up tight. So asthma's that lower, it tights and it squeezes it so you can't breathe. Now, our goal is to prevent asthma attacks, right? So do all sorts of function tests, skin allergens, etc. I mean, asthma is a problem, but remember, children need to be kids. So you need to let them be normal. But if a kid is allergic to grass, you wouldn't have him playing baseball or soccer or one of those things. You would have them maybe in tennis that was on a, different courts that wasn't grass, right? So again, it's monitoring what they have, working with them and letting them be kids. Do you all know what a spacer is? Step bottom left, it's for young kids, even adults who can't push it and breathe in at the same time, your little MDI inhalers. Remember asthma, we treat it with long-term and short-term and corticosteroids for those times where it's really bad. Now, status asthmaticus was my husband. true and real medical emergency. He could not breathe at all, on all meds, BiPAP, whatever. Our goal there was to keep him calm. Number one, calm him down. All right. And then do every medication you could do to open up the lungs and get those lungs moving. That's what we want to do. You know, COVID, we know that's out there today. We do mention it now. Thank goodness there's an immunization now. Now, cardiovascular. So before we even talk about cardiovascular, let's go back and let's look at how does blood travel around the heart? Do you remember the names of the valves? Those are things you're going to have to know. So let's start with blood coming back from the body in the inferior and superior vena cava, and it just gets into that right atrium, right? So the flow going into the right side of the heart is very low. Goes in the right atrium, and it goes through the tricuspid valve into the right ventricle, up the pulmonary artery, into the lungs, and then it returns to the left side of the heart, big pressure on the left atrium, through the mitral valve and into the left ventricle, and then that pumps it through the aortic arch to the body. You need to know the names of valves. You need to understand the way blood flows. So heart defects, mostly children, when we talk about it, is congenital defects, which means what? It means you're born with it. Yes, Cayman?
Do you mind saying that one more time, please?
About which one? Congenital?
Superior vena cava, right atrium, tricuspid.
Oh, you want to do the travel again?
I'm sorry.
No problem. Oh, no problem. We go from the inferior superior vena cava, goes into the right atrium, through the tricuspid valve, into the right ventricle, through the pulmonary valve, into the lungs, through the pulmonary veins into the left atrium, big flow on the left atrium, through the mitral valve, into the left ventricle, through the aorta, aortic arch, and into the body. Okay? Okay, so heart defects. Usually congenital is what we look at, but then we also have acquired. Actually, many of them are due to viruses, viral cardiomyopathies. I've seen a lot of them. What about lupus? Doesn't it attack organs? That's an autoimmune thing that goes on. So there's many ways the hearts can be damaged. So let's look at the heart and the blood flow. And let me give you now something that can happen. So you see that that left ventricle is red, and it goes up with the three things that go up to the upper body. That's your subclavians, etc., carotid arteries. And it goes down the arch, and it goes to the body. So that left ventricle pumps the blood out. It goes up and around. What if there was a kink? What if there was a kink after those three things that go up to the upper body? It's a kink, a narrowing in the hose. All that blood can't go down. So what would you see? So if all the blood pumping out of the heart can't go all the way down, it's going to go backwards, number one, and fill the lungs up. And number two, I'm not going to feel any pulses on the feet, on dissalis pedis, posterior tibial. No, ain't going to be there. Also, blood pressures is what you're going to look at next. When we don't feel pulses, you do a 4-extremity blood pressure. Now, remember I said blood's not getting down, it's going up. So blood pressures on the lower extremity are going to be lower. No blood, it's not flowing. The ones on the upper extremity going to be higher because all the flow is going up. And the other thing is, because blood can't go down, it's got to go somewhere. It goes back into the ventricle, left atrium goes back up in the lungs, fills it up, and you go into congestive heart failure. Wow, we just went to coarctation, which is what that's called, and into heart failure. It's just kinking the hose that went backwards. Think of the heart as a hose. You kink it, where does it go? It's got to go backwards. Where does it go? What can happen? Stretching of the ventricle. Does it flow from the right side to the left side to right side? All of these things. So cardiac dysfunction. Now, I just told you about a coarctation, and I just told you, what do you see? Now, let me tell you what you see about 2 months later when they still haven't figured out it's not a coarctation. And this is a true and real case for me, where the little girl came in, she was 2 months old, and they finally figured out must be something cardiac, failure to thrive. She was always tachypneic and tachycardic, and they thought she was infection, and she was treated. Nobody knew what she was doing. So we brought her to our hospital, and we found out it was a coarctation of the aorta. So for 2 months, this heart had been having this kink. Blood was going back to that ventricle, was stretching it out, right? And it was all the fluid is going into the lungs. So what did I see in that child? Well, the kid had no energy, couldn't eat. All that fluid is blocking all the areas in the lungs that will give oxygen, right? I'm just trying to survive here, and eating by mouth is barely even happening for me, right? So, activity intolerance, and that includes feeding, that's all it is. And if you're not getting nutrition, what happens? Developmental delays, because no nutrition ain't gonna happen. The child's not going to be turning over, lifting their head, cooing, doing all the things they should do. Sometimes we have a history, sometimes we don't. I think this is a great nursing diagnosis. Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. So poor weight gain, absolutely. And we know poor weight gain goes into the cognition and development and all of that. So looking at a cardiac kid, just looking at nutrition, we know that's going to be a problem. They're tiring out. They're not going to be eating as well as they should. Their color is not going to be good, whether there are children born and their O2 sats are going to be 70, and we're going to accept 70. I'm not going to tell you all the reasons why, but they can do it. It's all right. And these children are fine. But the color is not going to be that pink color. So yes, the color would be different. You can sometimes feel murmurs over the chest. As we get older, you're going to see those clubbing of fingers, and I'll show you pictures as we go on. We're going to be looking at their chest, their abdomen, their pulses, their heart rate, and then listening to breath sounds. Now, as I said, one of the easiest congenital heart defects to listen to is actually your ventricular septal defect, which is only a hole between the two bottom ventricles. So remember that left side is your heart pump, and it's flowing back over to the right side with that pump. So when you listen to a VSD with your stethoscope, a normal heart rate goes chikum, 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 chikum. A VSD goes pow, pow, pow. And if you touch their chest, you can feel the vibrations. You really can. That's how it was like, ooh, that has to be one of those. And then we'll do the echo and we'll figure it out. So do an echo, find out what's going on, look at the way blood flows, and yep, if there's a problem, the kid's going to go to surgery. Now, cardiac dysfunction, with doing the cardiac cath, they put two big catheters in the right femoral artery and femoral vein. So when they take them out after the procedure, that's our big, big thing. Okay. The dye, all of that, it doesn't bother the heart. You don't worry about cardiac dysrhythmias. No. What we worry about is bleeding from the site in the right groin where they've done the procedure. Okay. So you get this child back from cardiac cath. Number one, I'm going to look at the dressing before I even do a set of vital signs. I want to make sure there's no bleeding, because small babies can bleed their whole blood out in minutes. So we don't want that. So check the dressing, because the biggest risk is hemorrhage from the catheter site. You're going to check pulses. Now, that right femoral pulse is going to be slightly decreased because you had those catheters in there. Document it. Tell your next nurse about it. And again, if there's any fluids that we need to give, whether orally or IV, get them going. So congenital heart defects. This is when the heart just doesn't form the way it should. There's more of them than I ever realized when I started working in the cardiac ICU. The most common is that VSD. As I said, you can hear it, but it is the most common. The other more things that we see are the trisomies. And you're going to see there's different numbers here. 21, 13, 18, there's 15, there's 11. There's all different sort of trisomies. The smaller the number, the more problems, the more could be. I actually had a 11 that was blind, couldn't breathe, needed a ventilator, had half a heart. I mean, it goes on and on, the severity of that child. So remember again, I told you the blood comes in the right side very slow, right? It just gets back there after all that heartbeat. The left side flows coming in by that pulmonary artery and going out to the body. So any hole on the right and left side, blood's always going to go to the right because flow is left. That's a shunt. Remember, that's the shunt that we're talking about. Now, increased pulmonary blood flow. Well, if I had a hole in the upper or lower chamber, I'm going to be taking blood from the left side back to the right side because that's the hole. It's going to go to the right side and it's going to go back in the lungs. So that's why it's increased pulmonary blood flow. Now, a patent ductus arteriosus is fetal circulation. All I want you to remember this is it's the oxygen giver when you don't get oxygen anywhere in the body. This is a connection between the lungs and the aorta. So oxygen can get to the body. So all I want you to remember about it, and we'll go from there. How to keep it open, how to close it. There's times where we need it. We've already talked about coarctation of the aorta. We know it's a kink in the hose, right? Valves can also have kinks in them. Stenosis means narrowing. A or atresia means nothing, A, without. So you have aortic pulmonic stenosis narrowing, which again, all the blood can't go up, so it goes backwards again. Depends on how much stenosis is there. And then I want you to think about decreased pulmonary blood flow. And this has to do with something on the right side is not letting blood going into the lungs. Now, you will see on every nursing exam, every HESI, every NCLEX, any type of nursing thing, you're going to see the diagnosis tetralogy of flow. They love that one. And this is what we call those TET spells. This is where the baby goes from O2 sats of 100 and it can go to 10 in about 10 seconds. And it happened to me one night at 5 a.m. Little Nolan decided he was going to have a TET spell on me. And he went from pink to black. It was amazing. It's scary as heck. And we're going to go into treatment there. And then here's one, transposition of the great arteries. The two upper components, the aorta and the pulmonary artery, are just switched. Transposition, they're transposed. So this is the one that you need an oxygen giver because no oxygen's going to the body. And then I'll just mention the hypoplastic left heart, the most severe of all of them. And this one, usually it's 3-stage surgeries, and many of them end up with transplants. So that patent ductus arteriosus, oxygen giver. I want to put oxygen from the lungs to the body because my heart's not mixing it right. So I'm going to do something to get it there. And that's keeping that PDA open. So at birth, we have it, right? Mommy had it open. Mommy gives this hormone called prostaglandins, and it keeps this PDA open. And this keeps that oxygen going along. Well, normal delivery, within 21 days it closes, usually a lot sooner than that. Now, when we have it open, this PDA, you hear a washer machine murmur, like a washer machine. It sounds exactly like that. The other thing is many of these children end up with arterial lines, umbilical arterial lines, and we're monitoring blood pressures closely. And if you notice here, they have what we call a wide pulse pressure. So a normal blood pressure on a newborn baby is 60 over 40, normal. 60 over 18 would be somebody with a PDA. The diastolic number is very, very low. And as that PDA closes on its own, or if we want to close it, we can watch that diastolic number come back up to about 40 where it should be. It's a pretty neat thing to close this up and to watch that pulse pressure change. So keeping a PDA open, why would we need it? That's that transposition of the great arteries. And look, tricuspid atresia, no blood's getting to the lungs. There's no opening to the right ventricle. It can't get to the lungs. I need oxygen. Give me an oxygen giver. Give me a PDA. That's how I want you to remember that. So PDAs, they're open from mommy. And then when mommy leaves, the prostaglandins are gone. They usually go away. Now, what if I need that open for that transposition of the great arteries or the tricuspid atresia? I can give synthetic prostaglandins in a slow, continuous infusion, and that will help with cardiac output and oxygen saturations levels, right? It gives oxygen to the body, and it works really well. Now, many of your premature infants, many of them, this is what I see the most, they're born and their PDAs never close for whatever reason. So you've got this heart, this overflow in the lungs and, really damaging the lungs. If you think about it, it's too much flow. So we can close it with a medicine. And it's called a medical closure. And it's done with indomethacin or indocin. This is an old before ibuprofen back pain medicine called indocin, indomethacin. It's an NSAID, but it's IV. I was so confused when I first started using it. Again, it's a 3-dose. You've got to watch your all sorts of things with it, but 3 doses. As I said, as we're giving those doses, I'm watching that pulse pressure come back and I'm watching that murmur. I can't hear it anymore. So these are a couple about blood flows. I just have them there for you to look at to show rights and lefts, etc. So congestive heart failure. This could be that coarctation, that blood flew in there. Or this could just be a heart that's just so weak it can't pump. Therefore, the blood goes up into the lungs and it sits there. Does it matter how it happens? No. You're dealt with a child in congestive heart failure that can't eat, can't breathe, and is just, struggling. Your lungs are full of fluid. You're tachypnic, you're tachycardic. One of the things that you see with congestive heart failure, and especially if you know it's a congenital heart, you're going to see an increase in weight. Why? The fluid's in the lungs now. We're not getting rid of it. So it's showing extra weight as fluid. So these children, we do daily weights every morning, night, whenever they come in, usually say, okay, that's going to be the time of your weight every day. And hopefully they'll do it on the same scale too. But we look at, especially the newborns, small ones, looking at those changes. A change of 30 grams, 50 grams in a day is way too much. So we'd be looking at, is it fluid? So how do we treat it? Well, we got to get that fluid off. So that's your furosemide, your Lasix, right? Improve cardiac function. That would be some sort of medicine. Milrinone, Primacor is actually one of them. Digoxin is one of them. You don't have to know the names. Just know that function, cardiac function you want to improve. And then you want to decrease cardiac demand. So you would do cluster care. How else would you treat this child? You'd be feeding them smaller quantities of formula or breast milk, but with higher calories. So with less effort, they're taking their calories, their nutrition, because they have higher calories in their formula or breast milk. So they're saving energy. So that's going to help them gain weight during the time where their lungs are so full of fluid. So many times we give digoxin. Do you remember digoxin from pharmacology? Same thing. as adults, as in children. In fact, most of the meds that we give adults, we give children. We just give micrograms per kilo, milligrams per kilo. We just give it that way, not just a global, 2 Tylenol every 4 hours. So digoxin, count apical 1 full minute. Check electrolytes, potassium. If potassium's low, you're not going to give it. And if you have a recent digoxin level. Now, sometimes when you have a child on digoxin, they might only show you a little bit of vomiting. That might be the only signs and symptoms of dig toxicity. Now, an adult has yellow things and stuff and visions and whatnot. A child can't tell you that. But that retching, the nausea, the vomiting, that's something that you could see. Now, what's the heart rate also? It might be okay because the kid's retching and vomiting. I would call the doctor and say, the kid's vomiting, can we check a recent dig level? A doctor will never tell you no. And that will make sure they're not dig toxic. So again, we're going to decrease their demands, maintain their nutrition, and get them calmer, and we're going to get that digoxin in, get that heart working. Hypoxemia happens a lot. As I said, we do have one condition, is hypoplastic left heart. Sometimes O2 saturations of 70 to live on for the first while is normal. We don't get them up to fully saturated till about 3 years old, and not even completely. So hypoxemia is a big thing. Now, what do I want to tell you about hypoxemia and what you need to look at? Well, your body's pretty cool. When your body doesn't have oxygen, like in a congenital heart defect, it says, let me produce more red blood cells. Because what do red blood cells do? They carry oxygen. So if the red blood cells are carrying oxygen, I'll produce more and I'll have more oxygen. But there's no more oxygen. It's still the same, but you have all these extra red blood cells there. So you go polycythemic, which means your hemoglobin hematocrit might be 18 and 54, not 14 and 42. You see what I'm saying? Your hemoglobin hematocrit will be very high. The blood will be black almost. It's so concentrated. And that's what clubbing would look like. That would be a hypoplastic heart. And that'd be someone, 10, 12 years old that would have those fingers. So again, with anything congenital, it's all about educating, teaching children old enough that you can, developmental level, of course, and always planning for discharge. The one thing I've always found is cardiac parents are the best. I already did cardiac calf. Bacterial endocarditis, something that can happen, some sort of infection inside the heart lining. This is something that's going to require 1 hour before procedures, a dose of antibiotics. It's just preventative to keep that heart safe. Now, this is something caused by a strep infection. There's 2 conditions. One's going to be in week 8, and that's your GU condition. And then we have this one in the cardiac chapter, and it's all due to a strep infection that wasn't completely treated. They end up with something called rheumatic fever. And what happens is you're going to see a child all of a sudden, swollen glands, skin's going to get a rash. They're going to get this weird movements called chorea. They can't control themselves. And you can also get heart valve damage. The mitral valve can be damaged. Now, usually it gets to the point where maybe the rash brought them to the doctor, or maybe those weird central nervous system sort of irregularities, and it brings them into the doctor. And they say, okay, well, have you had a sore throat or been sick lately? And usually that's what it is. They've been sick and it wasn't treated, or they thought it was a virus and they didn't give antibiotics. Now, the cool thing about rheumatic fever is if we catch it in time before the heart valve was damaged, everything can be turned around. High dose antibiotics, that's all it is. So rheumatic fever is due to a strep infection. Kids can get high cholesterol. We never checked them before. We're starting to do it now. How do we treat it? Diet. Just like we would. Diet is the best thing for that. Children can have slow, medium, irregular heartbeats. I've actually seen pacers in children less than 2 years old because their heart rates are too slow. Anything can happen. Pulmonary artery hypertension is when flows go into the lungs and the lungs get upset and says, "Oh, you're going to damage me," and they tighten up. And that creates a lot of issues with oxygenation and CO2 exchange, and they tighten up. Okay, again, this is a child that you would do cluster care. This is a child that you wouldn't overstress because they will get short of breath, get that tightness in the chest because they're not getting oxygen because their lungs are tight. It doesn't get around as it needs. And you don't get oxygen, and then you're dizzy. I mentioned cardiomyopathy. Usually it's that viral thing, sometimes infections, but it could be like lupus. And the heart gets big and floppy and it gets to the point where you cannot tune it up anymore, as I call it, and it needs to be a heart transplant. I've seen quite a few actually transplants in some of my cardiac kids. I had some kids, I've got one child right now who's 19 years old. He's had it now for a little over 10 years. So I think he's doing all right, little Thomas. Um, anyway, when we talk about heart transplant, the biggest concern is rejection. Post-op surgery in children having open heart is they've opened the chest. They're going to have a chest tube, 1, 2, 3, 4, 5, depending on the kid, surgeon, et cetera, et cetera. Now, I've worked adults and I've worked also children and open heart, and I've worked nights. When you work night shift in the adult ICU for the open hearts, they come around at 6 o'clock in the morning, pull out all the chest tubes. So I've seen quite a few chest tubes being pulled. And the one thing that I remember overwhelming is the patients were telling me, "Oh, that burnt like heck. Oh, it hurts." Because it's like a quick, it hurts, and then it goes away. So with children and anybody, please make sure, get your vital signs, know where your baseline is, and medicate them before pain. And let them know what's going to go on. Have them sit up, all right? Not laying down, sit them up. And please be honest. It's going to burn for a second, that you'll hold their hand. You want to count to 10 with me slowly, and we'll do it together. And sometimes that will help. Again, always medicate. We're checking blood pressures on kids younger and younger. I mean, I look at the changes in my world. It used to be less than 5. We didn't. Well, now we check them on everybody. We know hypertension can kill things like kidneys, right? So we need to be checking it earlier. Another cardiac disease is something called Kawasaki. Has nothing to do with the motorcycle. It's called Kawasaki, and it's what we call a systemic vascularitis. What does that mean? The vasculature, or the vessels, get an inflammation, and little microembolus can be formed and go around the blood system with it. Our biggest concern with Kawasaki is that it's going to form a coronary artery aneurysm and burst, and that would be the end of the child, right? So these children usually come in, they have a big fever, they have a rash, they're going to have these big red eyeballs. I'm talking glow in the dark. You've never seen eyes this red before, okay? You're going to see lips that are red and cracked, strawberry tongue, swollen glands. And then the other thing we look at is the palms of the hands and the soles of the feet. Sometimes they're blistery, or sometimes they're cracked. Now, again, Kawasaki is a virus, but it needs to be treated because we need to protect those coronary arteries, right? So we need to boost that immune system. So we give IV gamma globulin, or IVIG. And that's IV. And then we give aspirin, high dose aspirin. It's the only time you're going to do it, high dose aspirin. And why do we give aspirin? Well, what is aspirin? It's an anticoagulant. It thins the blood. So in case those little vascular itises flowing around, it's going to help thin them out and prevent problems. There are some physicians now that are going to Coumadin, but usually IVIG, high aspirin. We already basically went over that. Shock. Shock can be any sort of shock, but remember, in children, it's usually septic. The biggest cause is infection. Anaphylaxis, we know this is my little Christian takes a peanut in and all of a sudden he's going to blow up. He's going to go anaphylactic pretty soon. But again, what do we want to do? If everything's swollen, you can't breathe. And again, giving the EpiPens, etc., and avoiding it. It's to the point where, teach that child. I mean, little Christian by the age of 3 wouldn't take anything from a stranger to eat before he asks, does it have nuts? I mean, it would be a piece of corn. Does it have nuts? But at least he was asking, right? He was taking proactive in his care. As I said, septic shock is one of the big things in kids. Toxic shock syndrome, tampons, adolescents, it's a big thing. So, question. Surgical closure of a patent ductus arteriosus would result in which of the following? Well, let's go back. What does the PDA connect? It connects the lungs, pulmonary artery, to the aorta. So if we close that up, what would happen? What do you think?
Prevent the return of oxygen blood? Probably.
Yep, absolutely, because now it can't flow back up there. Any questions? A lot of stuff in cardiac and respiratory, isn't it?
I just want to break.
You want a break? Okay, we can go till 4:30. How's that? That gives you 13 minutes. Go. I'm not going to argue with you.